Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagaipet. We were discussing about the acute appendicitis, and yesterday we have discussed about the differential diagnosis. So the differential diagnosis of acute appendicitis is the differential diagnosis of acute abdomen. So any condition which produces acute pain in the abdomen should be considered as a differential diagnosis for acute appendicitis, because it is one of the most commonly seen abdominal acute condition where surgery is required. Just I will summarize all the differential diagnosis. So differential diagnosis depending upon the age. In infants and children, so what are the things to be considered as a differential diagnosis to acute appendicitis? Enterocolitis, acute mesenteric lymphadenitis. Please tell me the important sign to diagnose acute mesenteric lymphadenitis. What sign will help you to make the diagnosis? What about others? So those who are attending this class, please answer. This is only for my assessment, how much I am able to influence you to learn. Okay, that's right. It is shifting tenderness, then Meckel's diverticulitis, intussusception, Henneck's colon purpura. So in this case, the patient will have abdominal pain. The pain is because of vasculitis. The vasculitis is a generalized phenomena here. So vasculitis affecting the abdominal viscera can cause abdominal pain. This is a self-limiting disease. Then lobar pneumonia. How lobar pneumonia can present as pain abdomen? The lower lobe of the lung, if it is inflamed, if there is consolidation, then there will be referred pain onto the upper abdominal wall. So lower lobe lobar pneumonia, basal pleurisy, and myocardial infarction. So these three conditions are also the differential diagnosis for acute abdomen when all age groups are considered. Then differential diagnosis depending upon the age of the patient. If it is a adult, then what is the differential diagnosis we should consider? Peripheral peptic ulcer, acute cholecystitis, ileal perforation, ureteric colic, intestinal obstruction, regional enteritis, acute pancreatitis, rectus sheath hematoma, acute cholecystitis, torsion of the right testis. So the differentiating points already we have learned it in the previous class. Can you tell me one of the common causes of ileal perforation in our country? The common causes of perforation of the ileum. Yes, it is typhoid ulceration. Tuberculosis perforation is uncommon. Tuberculosis usually produces chronic granulomatous lesion. That's why there will be fibrosis. So there may be hyperplastic or stricturous growth. The other variety, that is ulcerative variety, also has a lot of fibrosis in the base. That's why tuberculosis most commonly manifests with strictures and adhesions. Sometimes it can perforate. But as a whole, if you see ileal perforations, the commonest ileal perforation is due to typhoid in our country. The other causes of ileal perforation being the non-specific ulceration due to Yersinia infection. Then in adult females, so we should consider the pelvic disorders: metal smudge, acute salpingitis, ectopic pregnancy. That means ectopic pregnancy with either tubal abortion or tubal rupture. Then torsion of the ovarian cyst, acute pyelonephritis. So these are the things to be considered in adult females. In elderly, intestinal obstruction, mesenteric infarction or acute mesenteric ischemia, diverticulitis, aortic aneurysm threatened rupture. So these are the differential diagnoses to be considered depending upon the age. So when a patient comes to you with the acute pain abdomen, you have to do certain investigations. Tell me, I told you in the previous classes some standard investigations to be done in every case of acute abdomen. So please tell me those. So what are the investigations you do for a case of acute pain abdomen? Yes, you are right. You have to do urine examination, especially for microscopy. Then you have to do plain X-ray abdomen in erect and supine positions. Then serum amylase estimation, ultrasound scan of the abdomen. So these are the investigations to be done in every case. So here also in acute appendicitis, you do these investigations, and whenever you suspect some organic inflammation, you must always do the total count also. So the blood count, polymer for nuclear leukocytosis will be there, more than 15,000 per cubic millimeter. Urine examination, microscope examination to differentiate it from pyelonephritis, ureteric colic, and porphyria. So in these conditions, the urine will show certain changes, but in case of acute appendicitis, the urine will be completely normal. Then pregnancy test in case of suspected case of tubal pregnancy. Not only suspected cases, in all married women who are fertile, you must do pregnancy test. Plain X-ray abdomen erect posture to exclude perforation, serum amylase, ultrasound scan. Inflamed appendix may be seen as non-compressible, aperistaltic, tubular structure with a dilated lumen and thick wall. So like this. So this is a patient with acute appendicitis. So you can see a dilated tubular structure. And even if you keep the probe for few minutes, you won't find any peristaltic wave in this. So there is a aperistaltic tubular structure. And it has thickened wall with fat streaking in the mesentery. That shows edema. But though it is mentioned in the books, it is not reliable in adults, but even in adults, the ultrasound scanning done with a high resolution, with a good sonologist, you can make out appendicitis in majority of the cases. It is more useful to exclude pelvic disease like tubal pregnancy and ovarian cyst. CT scan in equivocal cases where the clinical signs and symptoms are not very typical, and ultrasound scan is not able to give any information, then CT is useful to diagnose. It is both sensitive and as well as specific. Still, if you have a doubt, any acute abdomen, you should not wait for too long, because if you wait for too long, the infection will spread and the patients will develop later many complications. So if you have a doubt about acute appendicitis and all the investigations are negative or equivocal, then you can go ahead with laparoscopy. Treatment of acute appendicitis. The treatment of acute appendicitis is appendicectomy by open or by laparoscopic methods. So the best thing to manage these cases is by laparoscopic appendicectomy or by open appendicectomy. The surgery should be done without unnecessary delay. Some surgeons practice non-operative treatment in the following conditions: uncomplicated appendicitis with absence of fecalip, perforation or abscess, and in patients who are less than 40 years of age. So when you strictly by clinical methods and investigation can demonstrate that it is a catarrhal appendicitis without any obstruction, and there is no evidence of any perforation or collection of pus, and patients are less than 40 years of age, some surgeons, they go ahead with conservative management. Because it's inflamed condition, simple catarrhal, there is no obstruction. So when catarrhal inflammation can be managed by conservative management, that is with rest, antibiotics, IV fluids, analgesics. Within 3 days or 4 days, the symptoms will resolve. So that is the idea of following conservative management. Of course, this is not being followed by all surgeons universally. So there is one school of surgeons at present who are following this conservative management. So, but in examination, if examiner asks you what is the treatment for acute appendicitis, you should simply mention the surgery is the management for acute appendicitis. That is appendicectomy. So what are the contraindications for doing an emergency appendicectomy? When a mass has formed. So when we have seen in the progress of the disease, the acute appendicitis can either resolve completely, or there can be localization with formation of a mass, sometimes an abscess, or there is spreading peritonitis. First there is localized peritonitis, later there is spreading generalized peritonitis. So what are the contraindications for emergency surgery when appendicular mass has formed? Why it is contraindicated? Because the inflammation and infection are localized in the right iliac fossa. If you disturb the inflammation, because there is a mass, what is the mass? It is this appendix whose surface is coated with a lot of fibrinous exudates, and these fibrinous exudates cause additions of surrounding congested bowels, and this is wrapped by greater momentum. So if you want to do appendicectomy for this case, first of all, you must unwrap the greater momentum. you must release the adhesions, fibrinous adhesions. Fibrinous adhesions are just thin glue-like. So with your finger, you can break those adhesions. So you have to break out all those adhesions, separate the appendix, and remove the appendix. So by doing this, what you are doing, you are opening up a place where the inflammation has been completely localized. So there is there can happen a spillage of exudates into the general peritoneal cavity and can result in spreading peritonitis. That's why when there is a localization, what you do is you help the body to get more localized and do not spread. So you do conservative management for appendicular mass. So that is about acute appendicitis. One of the sequelae of acute appendicitis is appendicular mass. This is the appendix. This is the inflamed appendix. So when our appendix is inflamed, the serous coat is congested and adjoining bowels, because of contiguity of the structure to the bowels, that means terminal loops of the ileum and the base of the cecum, they become inflamed. That means they become congested and edematous. And there is fibrinous exudates exuding from the serous coat of the appendix. And to these fibrinous exudates, the surrounding bowels and cecum get adhered. So it becomes a thick mass-like. And the greater momentum, which is hanging from the transverse colon, so it is a very large, wide structure. So it can cover the whole of the abdomen. It can go into the pelvis also. With the bowel movements, it will be moving all the parts of the body, all the nooks and corners of the abdomen. So when it is moving with the respiratory movements and bowel movements into the all nooks and corners of the peritoneal cavity, when a fibrinous exudates are present, so it will be adhered to that fibrinous exudate area. That is how the momentum goes and adheres to the site of inflammation. Not that it has some legs wherein it can identify inflammation and go there and get stuck there. It is not like that. It is adherent only because of its large mass, which fills the whole part of the abdomen. And with each respiratory movements, the abdominal wall is moving up and down or in and out. And the bowel movements also will aid in movement of the momentum to all directions. So when it's moving like that, if any fibrinous exudates are there, so it will be adherent there and stuck there. That is how it will be adherent there. So these bowels here, they become congested and edematous. These edematous bowels, now with the fibrinous adhesions, they adhere to the structure, and the greater momentum also covers there and gets adhered at that place. So the whole thing is appendicular mass. And in the middle of the mass, there may be few exudates. It is a mass of inflamed appendix and edematous cecal wall with adherent loops of edematous terminal ileum wrapped with greater momentum. It occurs 48 hours after the onset of acute appendicitis. So this usually occurs in catarrhal appendicitis. If it is an obstructive appendicitis, this type of localization cannot take place because usually the sequence of the events will be very rapid. They progress to gangrene, perforation, peritonitis in obstructive appendicitis. In catarrhal appendicitis, there will be slow progression of the inflammatory process from the mucosa to the serosa, and from there will be adhesion formations with the surrounding bowels forming the appendicular mass. So it takes about average 48 hours. It is due to the host resistance to contain the infection locally. It gets circumscribed by 4th or 5th day. When you examine the patient at the end of 2nd day, for example, you will find still some tenderness. and there is about some mild guarding also still is there. But when you examine by 4th day or 5th day the same patient, then the tenderness and guarding has decreased. So when the guarding has decreased, the abdominal wall becomes soft. So you will be able to palpate a mass. The mass is well localized by this time. The mass increases in size up to 10th day and subsides usually by 3rd week. So this is the progress of the appendicular mass. It starts by 2nd day, it gets well circumscribed by 4th or 5th day, and size increases in the 1st week, that means up to 10th day. Then it gradually reduces and then disappears by end of 3rd week. If an abscess forms, the mass increases in size. Clinical features: there will be classical features of acute appendicitis followed by a painful lump in the right iliac fossa. Sometimes the mass may not be palpable due to overlying guarding of the abdominal wall. General features of inflammation, namely pyrexia, malaise, and tachycardia, are present, but they are mild. Differential diagnosis: you are differentiated from all other masses in the right iliac fossa. So we have seen ileocecal tuberculosis as one of the causes for right iliac fossa lump. Can you tell me the other causes of mass in the right iliac fossa, which already we have discussed? In the chapter on intestines, we have learnt about some masses. It's very good. You have mentioned the common things. Ileocecal tuberculosis. It's very good. Carcinoma of the cecum. Amoebic granuloma. Crohn's disease. External iliac lymphadenitis. Because there are external iliac vessels, by the side of the external iliac vessels, there are lymph nodes. So there may be inflammation in those lymph nodes, and they may be swollen and they will tender. Investigations: blood counts, urine examination, stool examination for occult blood. If occult blood is positive, means you have to suspect some colonic lesion, either tuberculous ulcer, or it may be carcinoma of the cecum, or it may be regional enteritis, that is Crohn's disease. Then radiological investigations, ultrasound scan, bear a meal after resolution of acute stays. You should not do bear a meal when there is pain, tenderness, and guarding. Colonoscopy if you have a suspicion of ileocecal tuberculosis, Crohn's disease, or carcinoma of the cecum. Of course, in the differential diagnosis, I have not mentioned some uncommon things like the undescended testis, unascended kidney, then pelvic conditions like tumors, ovarian cysts, then the retroperitoneal tumors like fibrosarcoma arising from the iliopsoas sheath, then iliac bone tumors. So those things I have not mentioned because they are uncommon. But anyway, we will have a separate class on lumps in the right iliac fossa and lumps in the upper abdomen. So in that we will have a detailed discussion about these masses and the way to differentiate these masses. Okay, now the management of the appendicular mass. So already I told you the appendicular mass is nothing but the host defenses making it localized. So aim of the management is to help the body to contain the inflammation. So you help the body to do this job more perfectly, to identify when the inflammation spreads to the peritoneal cavity and to deal with by surgery. So don't be under the impression that the body will always be successful to contain the infection. Sometimes the appendicular inflammation may supersede the body defenses. So there is a mass is there, but appendicitis is still progressing inside. It is not resolving. Then what happens? The inflammation will spread to the rest of the peritoneal cavity. So if the infection is virulent, our body's defense is not so great to contain the infection. So the appendicular mass will form, but it will cause spreading peritonitis. So your second aim in the management will be to check for that spreading peritonitis, any sign of spreading peritonitis. When spreading peritonitis is there, means what? The body's defense mechanisms are not adequate to contain the infection. So you must do some surgical intervention in those cases. And the third aim is to manage the infected appendix after resolution of the mass. So once the mass is completely resolved, that means we have seen that by third week it will resolve. So wait for another 3 weeks. When the total inflammatory edema subsides, then you remove the appendix, though it is not having signs of inflammation. So why do you want to remove the appendix? The appendix is removed for the fear that once acute appendicitis and appendicular mass forms, there is a chance of getting recurrence. That means the patient will get acute appendicitis again. So again means the patient may be traveling. He may be in some other town. So he will be in a disadvantageous position to attend the hospital. He may be far off from his close blood relatives. That is why the chance of getting recurrent appendicitis is almost more than half. That is why many surgeons, what they do is they remove the appendix once the infection is completely settled. That means usually after 6 weeks. So how do you manage? So there is a doubt from Manogya, that is, can we include transverse colon obstruction in the differential diagnosis? No. Transverse colon obstruction cannot be considered here. Though it produces cecal fullness, it is only fullness, not a mass. That's why it cannot be considered here. Okay, let's come back to the management. The procedure of managing the patient with appendicular lump is by conservative management to enhance the body's defense mechanism. This is called the Ostner-Scherin regime. Because if you do surgery, once the mass is formed, there is a risk of damaging the inflamed and friable bowel in the vicinity. So the bowel wall, which is adherent to the appendix, will be having edematous bowel. So whenever edematous bowel is there, it is very fragile. So when you want to separate the adhesions, so when you are doing the separation, sometimes you may tear the bowel wall, causing perforation. And it is very well congested bowel because of inflammation. So when you are separating the adhesions, so there may be a lot of oozing of blood. So the operation will be bloody, dangerous, and sometimes may cause perforation and fecal fistulas. So what is Ostner-Scherin regime? Rest to the bowel. So how can you give rest to the bowel? By advising the patient not to take anything by mouth. And if there is any nausea or vomiting, you do nasogastric aspiration to empty the stomach and advise the patient nothing by mouth till peristaltic activity resumes and the pain subsides, usually for 1 or 2 days. IV fluids are given for 48 hours and liquid diet thereafter. Usually, I told you, it gets well circumscribed by 5th day. So once the particular mass is there, you give the patient rest to the bowel for about 2 days. After 2 days, the peristalsis will be normally resuming. Then you can advise the patient to take fluids by mouth. Till that time, only IV fluids are given. Enemas and purgatives are avoided. Why? What will happen if you give enemas or purgatives? The patient may have constipation. So the patient requests for a purgative or enema. Why you should not give? It will increase the peristaltic activity, thereby aids in spreading of the peritonitis. That is why enemas and purgatives are completely avoided. Antibiotics, broad spectrum antibiotics, which covers gram-positive and gram-negative organisms, plus metronidazole to cover the anaerobic bacteria, are administered. Analgesics and sedatives are given for 2 to 3 days because pain will be more during the time. Then most important is monitoring for spreading infection. So if the appendicular mass is causing spreading infection to the surrounding peritoneal cavity, so you must immediately stop your conservative management and go for surgical management. Tell me, how do you identify the spreading infection? What symptoms and what signs? First, tell me the symptoms. So if the infection is not getting localized, it is spreading. So a particular mass has formed, you have admitted the patient in the ward, he is under your care. Now on 5th day or 6th day, when you make rounds, you will notice certain symptoms and certain signs. So those will point out to spreading peritonitis. So can you please tell me the symptoms? The hypotension and oliguria, they do not occur early. They occur when the whole peritoneal cavity was inflamed and patient has gone into severe dehydration. Then only the patient will show manifestations of hypovolemia, hypotension and oliguria. So whenever I ask you to tell about this, how do you identify the spreading peritonitis? That means the earliest signs you must tell. What are the earlier signs? So the pain increases. That is number 1. Number 2, the pulse rate steadily increases. So every day you must record pulse rate and then check it out. So when appendicitis is there, there will be pulse rate is raised. Tachycardia will be there. So normally it will be around 70 to 80. So when acute appendicitis sets in, it will be around 100 or 110. So that will persist. Once the appendicular mass has formed, that means localization is achieved, then pulse rate comes down again. It will be around 80. When the peritonitis sets in, it is spreading, then the pulse rate will be again increasing. So every day you will notice the increase in the pulse rate. So there will be increase in the pain, there is increase in the pulse rate. Then what will happen locally when you examine the tenderness? Now, whenever you are treating a case of yes, very good. When you are treating a case of appendicular mass, you must draw the appendicular mass on the abdominal wall so that you can notice whether it is resolving or increasing in size. So the tenderness, which is earlier confined to the mass, Now it spreads to the surrounding region, like it may spread to the lumbar region, it may spread to the hypogastric region, or it may spread to the umbilical region. So there will be spreading tenderness and spreading guarding. So appendicular mass resolving means guarding gradually decreases, and by 5th day the abdomen becomes completely soft. But now the abdomen becomes again guarding. Guarding is there, and as the peritonitis is spreading, the bowels undergo reflex paralytic ileus. So whenever there is reflex paralytic ileus, there will be distension of abdomen. There will be vomiting. So when the appendicitis occurs, then first day patient has vomiting of gastric material. Now, when the appendicular mass has developed and it is spreading, there will be vomiting of bile and intestinal juices. So there is abdominal distension and there is bilious vomitings, pulse rate is raised, temperature is raised, tenderness and guarding, they progressively spread from one quadrant to the other quadrants. Of course, if it is left like that, if the patient is not in the hospital, if the patient is at home and he delays, then the patient may go into hypovolemia, hypotension, oliguria, and other systemic complications. So pyrexia and tachycardia, a rising pulse rate, not elevated pulse rate, a rising. Rising means today it is 85. By today evening, it is 95. Tomorrow morning, it is 100, like that. So if you see a continuous rise in the pulse rate, that is called rising pulse rate, it is sensitive and earliest sign of spreading peritonitis. There will be vomiting, pain becomes severe and diffuse, persistence of or spreading of guarding and tenderness, increase in size of the mass. So whenever there is increase in size of the mass, you must think of two things. Number one, an abscess has occurred. Number two, your diagnosis may be incorrect. It may be tuberculosis. It may be carcinoma. Sometimes tuberculosis and carcinoma can also manifest as acute pain. That is why whenever acute pain is there, you should not omit thinking about tuberculosis and carcinoma because they are chronic conditions. Sometimes you may omit from your differential diagnosis. No, don't do that. So they also should be always be considered. So once the lump resolves, appendectomy is done after an interval of 6 weeks. So we are doing surgery after an interval of 6 weeks. That's why this particular procedure is called as interval appendectomy. So this procedure is called interval appendectomy. Appendicular mass, once formed, it should regress. If the mass is increasing, means some other pathology is happening. That means the infection is progressing and there is collection of more fluid, the mass is increasing, or the pus is forming inside. So because of the host resistance, the mass continuously, gradually decreases. After 10th day, you will notice the mass will increase only up to 10th day. After 10th day, the mass will regress in size. If the mass is still increasing after 10th day, you should consider that there is a formation of appendicular abscess, or you must reconsider your diagnosis. So you must think about, am I missing tuberculosis in this patient, or am I missing more serious case that's carcinoma? And you must do the appropriate investigations like colonoscopy or barium enema. Contraindications for Ashner-Sterenism. So a patient has come to you on 4th day. The contraindication for Ashner-Sterenism. So a patient has come to you on 4th day, for example, with pain. You examine. You notice a mass. So what usually follow? You follow Ashner-Sterenism. But in certain conditions, you do not go for Ashner-Sterenism. Yes, this particular type of conservative treatment followed by interval appendectomy is called the Ostner-Schreien regime. And this particular regime, whenever it is asked in the examination, means you must write it only for the appendicular mass. The contraindication for Ostner-Schreien regime is children. Because the greater momentum is not well developed, the chance of spreading inflammation and general peritonitis is high in children. That's why even the child comes on 4th day or 5th day, it is better to do appendectomy operation. In old people, the incidence of gangrene and perforation are high due to atherosclerotic changes in the vessels. So it's preferable to do appendectomy rather than going for Ostner-Schreien. Then immunocompromised patients, or when the mass has not formed, or when diagnosis is in doubt, you have to go for surgery. So this I am showing an example of a old patient of around 70 years, came to me with the mass in the iliac fossa for the past 2 days. So actually he has pain for the past 4 days or 5 days. So the clear mass is there, but in spite of the mass, because he was very old, so operation was done. You can see such a big mass is there. This is the appendix, and this is the rolled up momentum. So the momentum has become very much edematous and congested, and actually it has rolled around the appendix. So this is the appendix, and this is the momentum. So the momentum along with appendix has been removed in this case. During the course of your conservative management, you may have to be forced to do surgery. That is, whenever there is signs of spreading infection. If the lump fails to resolve, ileocecal tuberculosis, carcinoma of the cecum, or Crohn's disease should be suspected. After 6 weeks, shall we definitely go for appendectomy or not? Because the appendicular inflammation has completely resolved. Then why should we do again interval surgery? We do surgery because of the chances of recurrence. So some surgeons, what they did was, they didn't operate upon. They have just followed the patient. They asked the patient to come every month to their clinic, and they are inquiring and they are examining the patient to see what will happen. So they have selected a group of appendicitis patients who were treated by Ostner-Schreien regime, and they have followed the patients for 1 year, 2 years, 3 years, like that. And they have found that recurrent appendicitis does not occur in great majority of the patients. And so some advise surgery only if the patient develops another attack. So this is only one school of surgeons' thought, not the general philosophy. The general principle of treatment of acute appendicitis is appendectomy emergency operation. The treatment of appendicular mass is Ostner-Schreien regime followed by 6 weeks later interval appendectomy. These 2 things you remember. Some surgeons, they think about why to do. So whenever some people have the why in their brain, it more prominently will be there. So those patients will be questioning each and everything. So those people, they have studied it and found that there may be a chance of, there is no need to do surgery because the recurrence rate is not so great as earlier thought. Some other studies have shown that appendicular neoplasm may be missed. Sometimes the cause for acute appendicitis is due to obstruction of the lumen by appendicular neoplasm, a carcinoid tumor or a carcinoma. So a small carcinoma or small carcinoid in the appendix cannot manifest with any other symptoms. So it can manifest only with symptom of appendicitis. So that patient you have treated with because he developed a particular mass, you have treated him with Ostner-Schreien regime. And if you still consider that he will not have recurrent appendicitis and leave him like that, the appendicular growth will increase and he will come to a later stage with widespread metastasis. So what some of the surgeons have noted was that, so especially patients more than 40 years old, they may have a mass in the appendix, a lump in the appendix due to carcinoma or carcinoid. That may be the cause for acute appendicitis, and you may miss it if you don't do appendectomy. So they strictly advise to do appendectomy. Hence, if surgery is not done, so if you're not going to do surgery for post-appendicular lump cases, you have to do follow-up with CT and colonoscopy to ensure complete resolution of the lesion. So unless you do CT scan and find a very well normal appendix without any neoplasm, then you can be satisfied. Otherwise, you must go for surgery. So whatever it is, all pros and cons will be there in any part of surgical management. As undergraduate students, you must remember that 2 points already I told you. The treatment for acute appendicitis is emergency appendectomy operation. If appendicular mass occurs, the treatment is Ostner-Scherin regime, followed by interval appendectomy 6 weeks later. Please remember this. The remaining things, of course, you can know that, but it is not for practice, just to know how surgeons of various thoughts are practicing surgery. That's all. So management of appendicular mass, considered management. If the during considered management it progresses and forms an abscess, it may resolve after 3 weeks. Go for interval appendectomy. If it forms an abscess, you do guided percutaneous drainage, and later interval appendectomy. If there is persistent mass or pain, or patient is more than 40 years old, you must always suspect other lesions. That's why you go for CT scan and colonoscopy. Other lesion detected, that means a tuberculosis or carcinoma or carcinoid is detected, do accordingly. No other lesion detected, you do laparotomy and do appendectomy. Considered management is abundant if total count, temperature, pain increases, or if paralytic ileus is present. Next condition is the appendicular abscess. Appendicular abscess is formation of pus in the appendicular mass. So usually the mass will dissolve by 10th day. But here, once abscess forms, the mass and general signs of inflammation continues to increase even after 10th day. Investigation, ultrasound scan or CT scan to see for liquefaction. Treatment, once the abscess is well localized, it should be drained extraperitoneally. So you wait for the abscess to get localized, then you drain it. If you can locate the appendix, you can do appendectomy because the structures are all edematous, congested. So in an abscess cavity, sometimes the appendix may not be able to be located. So don't dig for appendix. If appendix is easily located, do appendectomy. Otherwise, leave it like that and do appendectomy after 6 weeks later. Appendicitis complicating Crohn's disease. If the cecal wall is healthy at the base of the appendix, appendectomy can be performed. If the cecal wall is inflamed, local dissection of the involved ileum and cecum is advised. So this is the management of appendicular abscess. Santi, I could not get your doubt. What is localizing appendix? So what do you mean by that? Achha, in appendicular abscess, can we localize? Achha, in appendicular abscess, how to localize the appendix? So there is a doubt. Okay, by CT scan, you will be able to make it out. But during surgery, what will happen is the appendix may be embedded in edematous cecal wall or amidst the loops of edematous bowel loops. So if it is easily located, that means when you are doing drainage, if you can see the appendix, you can dissect it out and remove it. If you cannot locate it, then what you must see, you must separate the ileal loops, which are very much adherent there. You must separate the cecum from the posterior side, because it may be retrocecal appendix, which is situated behind an edematous cecum. So when you try to do dissection for edematous cecum or edematous ileal loops, there is a chance of perforation. That is why, because it is all abscess, so all the bowels will be very much edematous. They are soddy. So when you hold it tight with between your fingers, that will cause a hole in the bowels. So in all inflammatory situations, whenever you are dealing, when you are exploring, you must be very, very, very gentle towards the bowels. Otherwise, the bowel walls will tear and cause perforation. So because we are draining pus, yes, still in the cavity you will be able to see the appendix sometimes. Then you can do appendectomy. But the appendix is tucked in between the bowel loops, but an abscess is pointing. Then you can drain it. Then what is this extraperitoneal drainage? I will tell you in more detail about it when we discuss about the disease of the peritoneum. Tumors of the appendix, they are rare. The types of tumors: carcinoid tumor, carcinoma. Carcinoid tumor, already we have discussed in detail about carcinoid tumor in relation to disease of the intestines. This is the commonest neoplasm of the appendix. It arises from Kulczewski cells of the crypts of the labor cone. The cells are stained by immunohistochemical stain for chromogranin B. Clinical features: it may be silent because a small mass is there. It won't produce any problem. Or sometimes it may produce mild recurrent pain in the right leg fossa. Investigation: when you do laparoscopy or CT scan, you may be able to detect the lesion. Treatment is appendectomy. The tumor is less than 2 centimeters in diameter. The tumor is greater than 2 centimeters in diameter or associated with secondaries in the liver, carcinoid syndrome, or if the appendicular tumor is adherent to surrounding structures, you must do right hemicolectomy. That means in these situations, you must consider it as a malignant carcinoid. Carcinoma extremely rare in appendix. Treatment is right hemicolectomy. The diagnosis is made after appendectomy. A revision operation is done for right hemicolectomy. Sometimes you do appendectomy for acute appendicitis. You send the specimen for histopathology. So the pathologist opens the appendix and finds a small tumor causing obstruction in the lumen. And when he studies it, it proves to be a carcinoma. So the report comes as carcinoma of the appendix with acute appendicitis. Then what you must do? You must reopen the abdomen and do right hemicolectomy. Mucocele of the appendix. It is due to collection of mucoid material in the lumen of the appendix, causing it to distend enormously. If a small stricture of the appendix or some obstruction is there, sometimes there will be aseptic collection of mucoid material in the appendix, because the normal mucus secreted by the appendix cannot be drained into the cecum. So it goes on accumulating in the appendix, producing distension. And the distended appendix will be like this. Sometimes it can be distended to very huge size. Causes stricture, carcinoid, foreign body. So that means some obstruction. So the wall is enormously thickened, and you can see the mucoid appearance. The lumen is filled with a lot of thick mucoid material. You can find here a stricture. Complications of mucocele: when it ruptures, it can produce a condition called pseudomyxoma peritonei. The other cause for pseudomyxoma peritonei are colloid carcinoma of the rectum and mucinous cystoderma of the ovary. So these other two conditions also can cause pseudomyxoma peritonei. What is pseudomyxoma peritonei? I will explain it to you when we study about the disease of the peritoneum. The mucocele may be infected, may cause empyema of the appendix or pyocele of the appendix. Clinical features of mucocele: mild pain and tenderness in the right iliac fossa. Treatment is by appendectomy. The appendectomy operation. Surface marking of the appendix base is McBurney's point, that is spino-umbilical line, junction of lateral 1/3 to medial 2/3. That is the point of McBurney. So you usually approach to the appendix by an incision called gridiron incision. So this is the spino-umbilical line. So you make a perpendicular incision at the place of McBurney's point. Some surgeons, they make a curved incision in the skin crease lines at the McBurney's point. So this gives a cosmetic scar because it lies in the skin crease lines. Of course, if diagnosis is in doubt, you can go for a right paramedian, lower right paramedian incision. So these are the three incisions that are employed for approaching appendix. So first you inside the skin, then subcutaneous fat, then you will see the external oblique aponeurosis. So inside the external oblique aponeurosis in the line of its fibers, the fibers will be directed downwards and medially. So make the incision in that line. Then you hold the external oblique aponeurosis flaps and you separate them from underlying internal oblique muscle by blunt dissection. Then you will find the internal oblique muscle at perpendicular plane to the external oblique aponeurosis fibers. So you split the fibers, don't cut them, you just split the fibers. So with the help of a forceps, you split the fibers, and with the help of your fingers, you widen the aperture. Then you will get the transverse abdominis muscle. So that also is split in the fibers line. So external oblique only is in size. Internal oblique and transabdominis, they are just split and separated. Then what you see? You will see the fascia transversalis. So inside the fascia transversalis. Then you will see pre-peritoneal pad of fat. You just wipe it out. Then you will notice the peritoneum. So hold the peritoneum on artery forceps and you make a cut in the peritoneum. Then you have to locate the appendix and you have to hold the mesoappendix with the artery forceps and lift it out of the wound. So how to locate the appendix? The appendix can be in the retrocecal position. It may be in the pelvic position. It may be paracecal, subcecal, pre-ileal, post-ileal. So it can be various places. So once you open the iliac fossa, the appendix won't come and greet you with the good morning, sir. It won't say like that. You have to diligently search and find it out. So the best way to find it out is you hold the cecum. It is easy to hold the cecum. Cecum is always constant in that position there. So hold the cecum and lift it up into the wound. You follow the tinea coli, the 3 tinea coli, from forwards, from sides, you follow it. All these 3 will meet at one point on the posterior side. So at that place where the tinea coli meet, there will be the base of the appendix. Because the appendix is acutely inflamed, it is turgid. So the consistency of the cecum and appendix are quite different now because the appendix is inflamed. So with your finger, you can feel the difference. So you can hold the appendix and follow the base towards the tip of the appendix. So whether it is in retrocecal or retroileal or pre-ileal, you will be able to follow it. So first thing what you must do is you follow the tinea coli to their meeting point at the base of the cecum on the posterior side. At that place, there will be the base of the appendix. So you follow from the base of the appendix to the tip of the appendix. You hold the appendix with the help of appendicular forceps or with the help of simple artery forceps, catching it at the mesoappendix. So this is a Babcock's forceps which encircles the appendix and holds it. Then what you must do, this is the appendicular artery. So put 2 hemostats on either side and cut the appendicular artery and ligate this artery. So once the mesoappendix and appendicular artery are ligated and cut, so now the appendix is only simply hanging. So then what you do is you take your artery forceps and just place it here and crush the base of the appendix. Take it away and place it little 2 centimeters away from this place and hold it there. So where you have first caught it with the artery forceps, then there will be crushing of the appendicular base. That means it is not torn. Only the muscle coat is crushed. So there you will find a small groove. In that groove, you put a ligature and tie it. Then you incise the appendix and take away the appendix. So this is the appendicular stump. Then you take seromuscular suturing in the cecal wall. So you take a per-sting stitch or a stitch like this. This is called a Z stitch. You take a bite here, you take another bite here, then again a bite here, a bite here. So when you tie them together, automatically this appendix will be buried. So when you tie them close, so when you tie, that means pull them, these strings tightly together. So this will be get approximate to this, and this point will approximate to this. So that means all this gets bunched. So in this bunch, while it is getting bunched, then what you must do, with the help of the forceps, you have to push the appendicular stump inside. You have to push the appendicular stump inside. That means what you are doing, you are concealing the appendicular stump, not getting exposed to the peritoneal surfaces. Otherwise, there will be some fibrinous adhesions may develop at the tip of the appendicular stump. And you suture it. This is called seromuscular inversion of the appendicular stump. Then close the abdominal wall. You close the peritoneum, then close the transabdominis, internal oblique muscles, then close the external oblique aponeurosis, and close the skin. So incision, gridiron incision or muscle splitting incision. This is also called muscle splitting incision. This is also called McBurney's incision. This is also called gridiron incision. Made at right angles to the spino-umbilical line at McBurney's point. A midline or right lower pyramid incision is given in doubtful cases. Skin subcutaneous tissues are incised. External oblique aponeurosis incised in the line of fibers. Internal oblique and transabdominis muscles are split. Fascia transversalis and preperitoneal fat are incised. Peritoneum is incised. Appendix is located by following the tinea qualia of the cecum to its posterior wall. Mesoappendix is transfixed and cut. Appendix is crushed at its base and ligated with chromic catgut. A pulsing suture over the base of the cecum around the appendicular stump inverts the stump. Peritoneal exudate is mopped away and wound is closed in layers. So this is the procedure of the appendectomy operation. So very simple. The steps is isolate the appendix. Then hold the appendix. Ligate and cut the mesoappendix along with the appendicular artery. Put a ligature at the base of the appendix, excise it, invert it. So these are the simple procedure. Alterations in the procedure. Instead of a perpendicular incision at the McBurney's point, you can make a curvilinear incision that is called Lange incision. Sometimes there will be difficulty in accessing the appendix. The space will not be adequate for you because a long retrocecal appendix may be there. The appendix may be going up to the almost to the liver. Then the space is not adequate through a McBurney's incision. Then what you can do is you can cut the muscles. So that is called the Rutherford-Marson's muscle cutting incision. Sometimes the appendix is retrocecal and very much adherent to the cecum. So you will not be able to get the tip out. So what you do, first you ligate at the base, hold the base and gradually dissect it away from the cecum. This is called retrograde appendectomy. So when you start the appendectomy dissection from the base and go towards the tip, then it's called retrograde appendectomy. Some suggest they do not invert appendicular stump. For this procedure can be done by laparoscopy also. This is muscle cutting incision. You can see here this is a retrocecal appendix. So this appendix is almost adherent to the cecum like this. So when it gets inflamed, so how to remove it? If you just want to try to get it out, try to hold this at this point and then get it out, it is impossible. You cannot go to this point. That's what you do. You put a ligature here and hold at the base of the appendix and gradually dissect it from the cecum. So you can see here, this is the appendicular stump. It has been separated from the appendix and the appendix is gradually being separated from the cecal wall. So this is the retrograde appendectomy operation. For this is laparoscopic appendicitis. Complications of appendicitis and appendectomy operation. Complications of appendicitis, we have seen generalized peritonitis is the major complication, then appendicular abscess. Complications of appendectomy operation. Early postoperative complications, retention of urine, bleeding for appendicular vessels. So if you have not put a ligature correctly or if there is slippage of ligature, there will be bleeding. Then leak of the stump. With the ligature you put to the appendicular base, if it slips, then there may be leakage of the stump. Chest complications like bronchopneumonia, atelectasis, empyema, these are all complications due to anesthesia. Then wound infection, because we are doing it for an infective condition. So when you remove the appendix through the wound, so there is chance of getting the wound infection. The residual abscess. The abscess may form after appendectomy operation at the parasacral position, pelvic position, or subphrenic position. Then postoperative obstruction. If there is generalized peritonitis, there will be paralytic ileus. Then there will be mechanical obstruction due to adhesions. Sometimes because you are inverting the stump, it may lead as a lead point because it's protruding into the lumen. It may cause intussusception. Then other complications being thromboembolism, peritonitis, portal pyemia, ileocecal actomycosis, fecal fistula. Late postoperative complications being ventral hernia, that is incisional hernia. That means so wherever you do surgery, if it gets infected, the scar will be weak. Through that, the patients may develop hernia. Sometimes there may be inguinal hernia due to injury to the iliohypogastric nerve, because the iliohypogastric and ilioinguinal nerves, they pass through this plane. So when you are doing surgery, sometimes you may cause injury to these nerves. So injury to these nerves will produce weakness of the conjoint tendon. So that causes weakness of the inguinal canal posterior wall, resulting in hernia. Postoperative adhesions may cause acute interstitial obstruction. So here we have a doubt from one of our students. Normally also we cut the base of the appendix and remove the appendix. In the so-called retrograde appendectomy also we are cutting the base first and removing the appendix. Then why should it be called as retrograde appendectomy? This is the cecum. Normally the appendix will be like this. So you cut it here. Of course, cut the first meso appendix, then cut the appendix base and remove it. That's okay. But if the appendix is like this, situated at the posterior wall of the cecum, then what you are doing, you are not able to get the tip first, because tip is here. Tip is tucked in the posterior wall of the cecum, so you cannot get it out. So how you are getting the tip? But here you are holding the tip to the first time. So when you isolate the appendix, then what you do? You hold the tip with the help of an artery forceps here. Then you do surgery. It is not the procedure whether you ligate the base or not. First, what you are doing? You are holding the tip and removing the appendix normally. But when it is retrocecal and adherent to the posterior of the cecum, you are not able to hold the tip. Then what you are doing? You are holding the base. And from the base, you are going to the tip. Normally, you first to hold the tip and start the dissection from the tip to the base of the cecum by cutting the mesoappendix. But here you are doing the reverse way. That is why it is called retrograde appendectomy. I hope it is clear. Okay? Not clear? Santi, you see here, normally we hold the, okay, I will go to the previous slides. You can see here. Once you find the appendix, you will catch it at the tip. Then you start dissection from the mesoappendix. You cut the mesoappendix here, and if any remnant is there, you cut it here. So you proceed your dissection first by holding the tip and cut the mesentery from this side to the base. So you are cutting the mesentery from the tip side to the base. You are going like this. So your dissection is in this direction, from tip to the base direction. But if it's retrograde appendectomy, what you are doing, you are holding the base first, base of the appendix first, and cutting it here and dissecting the mesoappendix. Of course, mesoappendix is very short there. You are cutting it from base towards the tip. So you are going from the base of the appendix towards the tip. That dissection you are doing in case of retrograde appendectomy. But in case of usual appendectomy, you are following from the tip towards the base. I hope it should be clear now for you. Okay, that's fine. You have done appendectomy operation. You have done it for a male patient aged about 56 years, underwent appendectomy for acute appendicitis. He developed fever on 3rd postoperative day or 5th postoperative day. So postoperative pyrexia. This is one of the theory questions that are given in your theory examination. So that is why I am giving it separately here. So if any patient comes to you with or develops pyrexia after your surgery, usually for appendicitis, so how are you going to investigate? First, you examine the wound and abdominal wall for any infection. Examine for jaundice and tender hepatomegaly. That is called pileophlebitis. That means the portal vein radicals are inflamed. That produces jaundice and tender hepatomegaly. That means the infection from the site of appendectomy has spread through the portal vein tributaries into the portal vein. Examine the loin for tenderness or swelling. That may be due to pyelonephritis or due to retrocecal collection. Check urine for pus cells. Examine the left iliac fossa and do parietal examination. There may be abscess in the left iliac fossa or pelvic abscess. So whenever the appendicitis is there, there will be some amount of exudation of pus in the peritoneal cavity. So you must mop it out or you must give a wash. If you fail to do that one, this pus which is left behind, it may accumulate in the pelvis, causing pelvic abscess. It may accumulate in the paracolic gutter on the right side, producing right paracecal abscess. Or it may collect in the left iliac fossa and may cause left iliac fossa abscess. So you have to check for the left iliac fossa and parietal examination. Examine the legs for tenderness and swelling. Probably patient may have developed phlebothrombosis, that will be deep vein thrombosis. Examine the IV dip sites for thrombophlebitis. In tropical countries, exclude malaria. Sometimes after surgery, a quiescent malaria will become evident malaria. Examine lungs for immunitis. If no abnormality is detected, suspect subdiaphragmatic abscess and do ultrasound or CT scan to locate an abscess under the dome of the diaphragm. So this is about the disease of the vermiform appendix. Do you have any doubts? If you have any doubts, I will clear them. If you have no doubts, we will proceed to the next topic, that is the disease of the peritoneum, mesentery, and retroperitoneum. Okay? Okay, there is a doubt. What is the sign in which palpation of right iliac fossa gives pain in left iliac fossa? I think it is the reverse one. Palpation of left iliac fossa produces pain in the right iliac fossa. Yes, that is called the rousing sign. So it is reverse. That means when you press in the left iliac fossa, the bowels will be displaced to the right side because of a pressure. So the displaced bowels will now cause pressure over the appendix. And now patient gets the pain in the right iliac fossa. So that means the bowels which got displaced, that also displace the appendix. The displaced appendix will go and hit the peritoneum, and that produces pain. So that is the rousing sign. So that is often not seen, but in few patients it may be demonstrated. Okay, if you have no more doubts, we'll go for the next topic. The peritoneum, momentum, mesentery, and retroperitoneal space. Disease of the peritoneum. Peritoneal cavity is the largest cavity in the body. Okay, there is one more doubt, that is the Barpet bed shaking test. So bed shaking test or cough test or rousing test. So all these tests are same. You are making a movement of the appendix. So whenever appendix moves, it moves and hits against the peritoneum and causes rubbing, and that produces pain. So if you ask the patient to give a forcible cough, that also causes the same thing. So all these things are the same. Okay, let's come back to the peritoneum. Anatomy of the peritoneum. Peritoneal cavity is the largest cavity in the body. It is divided into greater and lesser sacs. Of course, all this cavity is filled with bowels and other viscera. So you can't see something like a space there, big space there. The space is just like this. You can see this blue staining. This is all the spaces between the bowel loops. So this whole thing is the peritoneal cavity. The whole thing is the peritoneal cavity. So in all these things, these viscera are very nicely packed, so that the space between them is just only few millimeters. Each pair of the bowels will have only few millimeter space between them. So this is the greater peritoneal cavity hosting all the bowels. And in the greater peritoneal cavity, there is one more lesser peritoneal cavity. This is called the lesser sac. So this is the peritoneal cavity. This is lined by peritoneal membrane. The bowels will protrude into the peritoneal cavity like this. So whenever they are protruding like this, what is happening? This peritoneum is covering its mesentery and it's covering the bowels and going like this. So we have two parts of the peritoneum. One is the part which lines the abdominal cavity. That is called the parietal peritoneum. The other one is visceral peritoneum. That means that part which lines the mesentery and the bowel. It is called the visceral peritoneum. So this is the visceral peritoneum, and this is the parietal peritoneum. This is how the mesentery has formed. The surface area of the whole peritoneum is 2 square meters. This is almost equal to that of skin. The peritoneum is of two parts: the visceral peritoneum surrounding the viscera and mesentery, which are innervated by autonomic nerves. Then the parietal peritoneum, which is lining the inner side of the abdominal wall. It is innervated by the somatic nerves. Peritoneum is lined by single-layered flat and polyhedral cells called the mesothelial cells, which have great regenerating capacity. Peritoneum secretes and absorbs fluids. The fluid is pale yellow and contains mainly lymphocytes. Normally, only few ml of fluid is found in the peritoneal cavity, because continuously the peritoneum secretes fluid and absorbs the fluid. The fluid is not static. Then why fluid is secreted? For lubrication of the bowels. The bowels should be moist so that they are undergoing peristaltic activity, so there will not be any problem. So for that reason, they are always moistened. Function of the peritoneum: pain perception by the parietal peritoneum, visceral lubrication, fluid and particulate absorption. If any fluid that has come out of the bowel loops by transmigration across the bowel wall, if any fluid leaks out, then the fluid is absorbed, not through a perforation, by transudation. Because of some hemodynamic changes or fluid dynamic changes, the fluid sometimes from the bowel wall will exude out into the peritoneal cavity. That will be absorbed. Inflammatory and immune responses. It has a lot of immune antibodies. So if any infection occurs, these immune responses and inflammatory responses will try to contain the infection. It has a fibrinolytic activity. If any bleeding is there, the blood clots are lyse after 3 or 4 days. That is because of the fibrinolytic activity of the peritoneal fluid. Then let's discuss the disease of the peritoneum. Peritonitis. Peritonitis is inflammation of the peritoneum. Causes microbial infections like appendicitis, tuberculosis, chemical injury due to leakage of bile producing bile peritonitis, ischemic injury, strangulated bowels or vascular occlusion causing peritonitis, the direct trauma by operative procedures. So whenever you do operation, do retraction, and do some maneuvers in the abdominal cavity, you are causing physical injury to the peritoneum. That will produce peritonitis. Allergic reaction, allergy to starch peritonitis. That means starch powder used as a dusting powder for the gloves in earlier days. So that starch used to cause some inflammatory action of the peritoneum. So out of all these things, microbial infection is the commonest and causes more severe changes. Classification: acute, chronic. The chronic is again classified into tuberculosis and non-specific. Acute peritonitis. As I already told you, bacterial infection is the commonest. Sometimes even the viral, fungal infections can also cause. The bacterial infections are, the bacteria are derived from the gastrointestinal tract only. We have seen the commensals in the guts. Sometimes they can undergo translocation into the peritoneal cavity. Can you tell me the conditions where or when the normal commensal bacteria transmigrates or translocates to peritoneal cavity? Under what situations the bacteria migrate from the bowel to the peritoneum? Very good. You have given correct answers. So it can be due to perforation. It can be due to ischemia of the bowel, where vitality of the bowel has been decreased, or it can be due to a progressive obstruction. So, and also due to some stasis, and also due to inflammation of the bowel wall. So all these things can cause transmigration. And the bacteria can be due to from the non-gastrointestinal bacteria. It may be viral. The gastrointestinal bacteria being aerobic and anaerobic organisms, Escherichia coli, aerobic and anaerobic streptococci, and the bacteriads. Less frequently by Clostridium welchii, still less frequently by Staphylococci, Klebsiella pneumonia. Gram-negative bacteria, they produce endotoxins. Source of infection by transmural migration due to infection, ischemia, or obstruction of the bowel, or due to perforation. So what all you have said that is being mentioned here. Then the bacteria can be from the non-gastrointestinal source. That means chlamydia, gonococcus, beta hemolytic streptococcus, pneumococcus, and mycobacterium tuberculosis. So all these things either from the genital tract in a female patient or from blood spread. Source of infection in young girls and women via the fallopian tubes, that means via the pelvic genital organs, or exogenous contamination due to trauma via drains, hematogenous spread. In immunodeficient patients, opportunistic peritoneal infection, example Mycobacterium avis, can occur. The infection may be localized or generalized. Local peritonitis, it may resolve or it may lead to abscess formation, or it spreads to the general peritoneal cavity from the site of sepsis. The localized abscess, localized infection can also become spreading peritonitis. Whenever there is spreading general peritonitis, because of the inflammation, the peritoneum secretes copious fluid. That means a lot of fluid secretion, and that it becomes a third space loss. So whenever there is third space loss, that will lead to hypovolemic shock. The gram-negative bacteria, they produce a lot of endotoxins. These endotoxins are absorbed and they can produce sepsemia and toxemia. Whenever there is peritonitis, there will be reflex paralytic ileus. This reflex paralytic ileus will cause sequestration of fluid in the gut. Again, that adds to third space loss. So the hypovolemia will be aggravated. And the paralytic ileus will be so severe that there will be huge distension of abdomen. This distension of abdomen can cause the splintage of the diaphragm. So there will be decreased respiratory movements, so causing hypoxia and respiratory embarrassment. So whenever there is general peritonitis, these sequelae will take place. That is why body tries to localize the infection whenever the infection occurs. We have just now seen appendicitis, how it got localized. So now let us see what factors in the peritoneal cavity help for localization. These are called anatomical factors and pathological factors. What is the anatomical factor? The greater sac of the peritoneum is divided into various compartments, which localizes the infection to these compartments. For example, there is appendicular perforation or appendicitis producing localized infection. This infection doesn't spread to the general peritoneal cavity so easily. Only in few patients there will be spreading peritonitis. When most of the patients gets localized. Why? Because of certain anatomical factors and certain pathological factors. What are these anatomical factors? The you can see these loops are there. If it is a big cavity like this, if infection occurs in one place, so it can spread into the cavity and can cause infection of any viscera here. But it is not like that. It is a very compact structure with cavity being filled with multiple loops of bubbles, momentum, mesentery, etc. So there is a lot of septations in the peritoneal cavity. So these septations are making the peritoneal cavity into rooms like. So there are about some 100 rooms. So in between each bubble loop is a room or a space. So there are multiple spaces. So if infection occurs in one space, it gets localized to that space. Unless the infection is overpowering, it will not spread to the other space. So the anatomical factors being localization because of the various compartments. So we can divide these compartments anatomically. So what are these division? Subphrenic spaces. So below the diaphragm, there are spaces. These spaces are created because of the presence of the liver and its ligaments, various ligaments. So various ligaments attached to the liver will make these spaces. And after the subdiaphragmatic spaces, next is the transverse colon and transverse mesocolon. So you can see the transverse mesocolon hangs from posterior abdominal wall and transverse colon is situated onto the anterior abdominal wall. So this forms a big septum like a horizontal transverse mesocolon, transverse colon. So horizontally, it divides the peritoneal cavity into two compartments, a supracholic compartment and an infracholic compartment. Then pelvis. There is another space, that is the pelvis. So the compartments are subphrenic space, supracholic and infracholic compartments, pelvic space. The pathological factors for localization. So whenever there is inflammation, there is secretion of fibrinous exudate. So this fibrinous exudate causes gluing or adhesion formation. So the surrounding bowels will come and adhere to that particular structure. We have seen how appendicular mass is formed. If fibrin is not there, if this gluing is not there, then what will happen? The exudate coming from the appendix will spread all over in the peritoneal cavity. But because there is gluing, the bowels will come and adhere all around. So this inflamed structure is localized here only, forming a mass. Then second factor is retarded peristalsis of the affected bowel. So whenever the bowel in the vicinity of inflammation, it will have lack of peristaltic waves. So because of the lack of peristaltic waves, so the infection will be contained there only. If peristalsis activity is there, means the infection will spread from one part to the other part. So there is a doubt, what is fibrin and what is fibrosis? Fibrin is nothing but the fibrinogen, activated fibrinogen is the fibrin. That is thin and filmy. That means if you stretch it with your fingers, the fibrin strands, they break out. They have a lot of gluing activity. So they are sticky. They behave just like glue. Fibrous tissue. Fibrous tissue is a mesenchymal tissue produced by the collagen or fibroblasts. The fibroblasts, they secrete this mesenchymal tissue. So that is a polymerized structure, polymerized mucopolysaccharides and aminoglycans. So all these materials put together, they get organized. There will be a lot of fibrils will be there. The fibrils undergoes arrangement. That's called condensation or maturation. So this fibrosis once forms, there will be 2 grades or 3 grades. So initially it will be immature, later it gets matured. So this is all because of deposition of aminoglycans. That is the fibrous tissue. So the tissue itself is different totally. Okay. So pathologic factors being number 1, adhesions around the inflamed organ, number 2, retarded peristalsis of the affected bowel. The third factor is the greater momentum, which comes and envelops the inflamed structures. Then surgical factors. So if any intra-abdominal collection is there, if as a surgeon you interfere and then drain those infected materials, so it will be localized. If you don't drain it, what will happen? These X-rays, they will increase in size, increase in quantity, and they will spill into the general peritoneal cavity. Then let us see factors for spread of infection. If it is a perforated viscous, then spread will be more, because once the perforation is there, there is some force involved in spilling. So the X-rays will not just seep out, they will be forcibly sprayed in the peritoneal cavity. Stimulation of peristalsis by ingestion of food, water, or by administration of purgatives or enema. So if it is a perforation, means it is getting the X-rays are getting sprayed over the peritoneal cavity. The second factor for spread of infection is the virulence of the organism. Third factor is young children who have an ill-developed greater momentum. Then fourth factor is disruption of localized collections. If appendicular mass is formed, if you dare to do surgery and separate all those adhesions, so the X-rays now will spill into the surrounding peritoneal cavity and can cause spread of the infection. So injudicious and rough handling, example appendicular mass or pericholic abscess. Then deficient natural resistance, that is immune deficiency states, like steroids, AIDS, diabetes, old age. So these factors cause the spread of infection. Clinical features of peritonitis. Early features. There are systemic features of infection and shock, because usually we have seen in peritonitis there is two factors. There is infecting agent causing septicemia. Number 2, there is fluid exudation into the peritoneal cavity. There is fluid sequestration in the bowels. So both these things will cause hypovolemia. This hypovolemia will cause shock. So patient will be having infection, septicemia, and hypovolemic shock. So the presentation will be, there will be pyrexia with rapid pulse, vomitings because of paralytic, and the vomitings are bilious. Local features of infection. What are the two important signs of peritonitis? What are two important signs of peritonitis? Yes, the two important signs being the guarding and tenderness. And in the tenderness again, rebound tenderness is more specific for peritonitis. If the guarding and tenderness and rebound tenderness are present only in one quadrant of the abdomen, that means it is localized peritonitis. If these features are there, generalized over all the quadrants, then we call it as generalized peritonitis. So local features of infection being pain and tenderness, rebound tenderness, guarding. Associated sequelae like paralytic ileus. So what are the features of paralytic ileus? What are the clinical features of paralytic ileus? Very good. So the signs and symptoms of peritonitis being abdominal distension, bilious vomiting, absent bowel sounds, constipation. So in generalized peritonitis, these features manifest diffusely over the abdomen. In local peritonitis, they will be confined to one quadrant of the abdomen. Late clinical features being there is progressive distension of abdomen without bowel sounds, peripheral circulatory failure, there is cold, clammy extremities, sunken eyes, dry tongue, thready pulse, drawn and anxious face with overactive L-off nose. Cold, clammy extremities are present for any case of shock. If the shock is due to loss of fluid, then these additional features will be there. That is sunken eyes. So eyes are drawn inside because of the reduced fluid in the generalized body. So all the body tissues, extracellular fluid has been depleted. So because of the loss of this fluid from the extracellular compartment, the patient will be having sunken eyes. Eyes will be drawn inside. Tongue is dry. Pulse is thready. That is, of course, because of hypovolemia. Drawn and anxious face with overactive L-off nose. This indicates the hyperapnea. This is called the Hippocratic phases. The patient finally lapses into unconsciousness. So this is the anxious look with sunken eyes, dry tongue, dried lips, pale, anxious look. Investigations: raised leukocyte counts, plain X-ray abdomen. So a patient came to you with diffuse tenderness and pain. You examined, there is guarding, there is rebound tenderness all over the abdomen, there is distension. So it is a case of generalized peritonitis. So it can be due to anything. It can be due to infection, it can be due to ischemia, it can be due to gangrene, it can be due to perforation. So usually in that condition, what you think is the common things you will consider. So far we have studied various diseases. So tell me the common conditions which produce general peritonitis. In what chapters we have studied about general peritonitis? Or what organs or what viscera of the abdomen cause general peritonitis in our discussion previously? We read about the gallbladder, we read about the liver, we read about stomach, pancreas, small bowel, large bowel, appendix, rectum, anus. So tell me some examples of cases which produce general peritonitis. Yes, you are right. We have seen peritonitis in case of the gallbladder, that is cholecystitis, appendicitis, perforated peptic ulcer, ileal perforation, strangulated bowel, and also we have seen in non-infective condition, that is pancreatitis. So what investigations do you do? If peritonitis is there, means it can be due to any of these things which you have mentioned. It can be appendicitis, it can be cholecystitis, it can be perforated peptic ulcer, it can be pancreatitis. So what do you do? The same investigation which I mentioned for acute abdomen. That means because it's an inflammatory condition, you must do total leukocyte count. Urine for microscopic examination. Plain X-ray abdomen in erect and supine position. What for? Why do you take plain X-ray abdomen? In peritonitis case, Very good. For two things. For air under the diaphragm, there is pneumoperitoneum, which indicates perforation of a viscus. That's all. We can't say it's perforated duodenal ulcer. Even ileal perforation also can cause gas. Colon perforation can also cause gas in the diaphragm. So you see the plain X-ray abdomen for two reasons in erect posture. Number one, for air under the dome of the diaphragm, it is called the pneumoperitoneum. Number two, for air fluid levels. So that can be due to intestinal obstruction or that can be due to paralytic ileus. Then you take the X-ray in supine position. What it will give you? Supine X-ray. That will show you the distended bowel loops, the ileal shadows, the jejunal shadows, the colonic shadows. That indicates that it is a case of paralytic ileus. Manognya, you are having some doubt, which I cannot understand. Please repeat it again. Do you mean to say that by looking at the shape, can we say the perforation is from the stomach, jejunum, ileum, colon, like that? Do you mean that? Or in something else? No. Whether it is stomach, duodenum, small bowel, or large bowel, when they perforate, they release air. That air escapes into the peritoneal cavity, and that air will go in, collect under the dome of the diaphragm when the patient stands erect. So that is why you will see only a gas shadow on the dome of the diaphragm. By that you can't say which part of the bowel was perforated. Then, in case of intestinal obstruction, there will be distended bowel loops. The distended bowel loops will cast a shadow, gas shadow. By looking at the border of the gas shadow, you can say whether they are the jejunal loops that are dilated, ileal loops that are dilated, or colonic loops that are dilated. So, by looking at the pattern of the gas shadow, you can mention whether jejunal, ileal, or colonic shadows in case of intestinal obstruction, not in the perforation. I hope it is clear to you. Okay, that's fine. So, the investigations for peritonitis being number one, total count, then urine examination, then you go for plain X-ray abdomen in supine and erect postures. Then you do serum amylase estimation to exclude pancreatitis. Then you do ultrasound scan to look for the gallstones, to look for the pancreas, to look for the appendix, to look for any cysts or masses which has undergone torsion, like ovarian cyst with torsion. Those things can be evaluated. Then, if it is a case of acute pancreatitis, suspected case, or if your ultrasound scan is inconclusive, you must do CT scan. So this is how you do the investigation. That means the investigations of peritonitis, acute peritonitis are same as that of the investigations of acute abdomen. This is pneumoperitoneum, a crescentic shadow under the dome of the diaphragm. So you can see here a crescentic shadow on the dome of the diaphragm along with air-filled loops in the abdomen. You can see here the pancreatic swelling. This is acute pancreatitis producing peritonitis. Then in doubtful cases, you can do peritoneal diagnostic aspiration. You aspirate the peritoneal fluid and look at the peritoneal fluid. So in any case of peritonitis, there will be abdominal distension. Under ultrasound guidance, you see where peritoneal fluid is collecting, either in the flanks or in the pelvis. You pass a needle and aspirate the fluid. Just look at it first. If it is greenish, the cause can be due to perforation, or it can be perforation of the gallbladder or CBD. If it is blood, it is due to ruptured ectopic gestation. If it is due to bloody fluid, that means thin blood with fluid, it is due to acute pancreatitis or gangrene of the small bowel. Clear fluid, intestinal obstruction, tuberculosis, gastroenteritis, rupture of hydatid cyst, rupture of ovarian cyst. Pus with water, perforation of viscous. Pus waterless, perforation of peptic ulcer, salpingitis, acute appendicitis. So these are the macroscopic features. That means by looking at the macroscopic appearance, you can come to a conclusion. The microscopic fluid will show neutrophils, RBC, or grams. By gram staining, you can make out whether it's aerobic or anaerobic bacteria that are involved. Treatment, the principles of treatment: resuscitation. Because the patient is having sepsemia and hypovolemia, you have to correct them by giving IV fluids, antibiotics. Specific treatment for the cause. Sometimes it can be surgery, sometimes it can be conservative measures. Peritoneal lavage and peritoneal drainage when you do surgery. Resuscitation, IV fluids, antibiotics, analgesics, gastrointestinal decompression by Rayleigh tube aspiration, monitoring and vital system support, because the patients will be having sepsemia and hypovolemia. So these things can cause multiple organ dysfunction. So you have to monitor them before they become dysfunctional, and you have to correct it. Specific treatment of the cause depends upon the etiology of the peritonitis. Surgery, non-operative treatment. Surgery is done, timing of operation. In any case of doubt, it is always better to look and see rather than to wait and see. Patient has come to you with peritonitis. You are not able to make out the diagnosis by all your investigations. Anyway, let me try for antibiotics and IV fluids for 3 or 4 days. You may think like that. But don't wait and see. It is always preferable to look and see. Whenever doubt is there, doubt is not cleared, infection is progressing, always look and see what is happening inside. So great number of patients die from delay than from an unnecessary laparotomy. So you do laparotomy, you will find acute pancreatitis is the cause. What you do? You don't do anything, just close the abdomen. Your colleagues may say you have unnecessarily done surgery for this patient. But if it is gangrene of the bowel, if you do surgery, you are saving the life of the patient. If you wait and see, the gangrene will establish and you can't do anything later, and patients will die even if you do surgery. So great number of patients die from delay than from an unnecessary laparotomy. So when in doubt, look and see. Indications for surgery: any history of perforation. That means if you do X-ray abdomen, there is perforation, pneumoperitoneum. Yes, surgery has to be done as early as possible after resuscitating the patient. Gangrenous viscous. How do you say gangrene? How do you say a gallbladder became gangrenous or bowels have become gangrenous? What signs help you to diagnose gangrene? No, I am talking about not looking at the organ. You have not done surgery. Abdomen is still closed. Patient is under your treatment, under conservative treatment. So when you suspect gangrene, for example, intestinal obstruction, when you suspect gangrene, in intestinal obstruction? Whenever patient develops rebound tenderness and guarding in intestinal obstruction, then you suspect gangrene. In acute cholecystitis, when do you suspect gangrene? When suddenly the symptoms worsen, the signs worsen. I mean, suddenly there is a big tachycardia, there is sudden spike in temperature, and patient condition becomes bad. That means he develops a lot of vomitings, guarding increases. Then you suspect gangrene. Spreading peritonitis. So when a particular pain and tenderness which is there in right iliac fossa is spreads to the other quadrants, then you suspect you have to do surgery. The procedure is surgery after resuscitation. So you do laparotomy, deal with the diseased organ. That means if perforation is there, close the perforation. If infected organ is there, it can be removed, means you remove it. For example, appendix. If gangrenous viscera is there, you resect the gangrenous viscera. After laparotomy and dealing with the offending viscus, the peritoneal cavity is thoroughly washed with saline. Abdomen is closed, leaving a drain. So this is how you do it. You pour ringer lactate or normal saline and take out all the fibrous exudates. You can see this white material. This is the fibrous exudate. And you suck it out. So you repeat it till the washings are clear. And afterwards, you leave a drain. That means you put a tube into the peritoneal cavity and close it. Because even after you do surgery, some amount of seepage of fluids will be there. So let them not collect in the peritoneal cavity. So you keep the tube at the site of the disease. For example, appendicitis, you keep it in the right iliac fossa. Cholecystitis, you keep it in the right hypochondriac region. The non-operative treatment indications, peritonitis due to pancreatitis or salpingitis, you don't do surgery. And in one condition called primary peritonitis of streptococcal or pneumococcal origin, if the diagnosis can be made with certainty, you need not do surgery. Method of non-operative treatment, nothing by mouth, gastrointestinal decompression by nasogastric aspiration, IV fluids, antibiotics, analgesics, monitoring. So the same standard principles. Monitoring and support of vital organ systems. Operative treatment should be considered if peritonitis is spreading or diagnosis cannot be made with certainty. So if you have a doubt, again, look and see. Don't wait and see. Prognosis, mortality depends upon the degree and duration of the peritoneal contamination and associated metabolic sequelae. Anywhere, if the peritonitis is there for more than 48 hours, the prognosis will be usually bad. So the other factors being the age of the patient, general health of the patient, nature of underlying disease. Generalized peritonitis carry a bad prognosis. With modern treatment, it carries a mortality of 10 to 40%. So we will stop it here. Tomorrow, we will continue this topic. Any doubts, please? If you have no more doubts, I will close this session. So tomorrow we will study about some important topics that are frequently asked in the theory examination, that is subphrenic abscess. So to understand subphrenic abscess, you should first of all understand the anatomy of subphrenic spaces. So please refer your anatomy book and read about subphrenic or subdiaphragmatic spaces. So then that will be easier for you to follow in tomorrow's class. Okay? So if you have no more doubts, I am closing this session. Wish you all good night. Thank you. Bye.